All right, we're gonna get started with our last session. So we're gonna get everybody back in. I know Dr. Tucker was working on it. Is he still working on it, Dr. Tucker, or is he back? So our last session is gonna be on the upper GI tract. And Dr. Tucker, you were supposed to bring people back. Yeah, didn't you say you were gonna get everybody back? Yeah, okay, perfect. Thank you. So the last session we're going to talk about esophagus and stomach, and it's a pleasure to introduce our partner and friend. You probably saw her on the screen. Really was a backbone behind our course yesterday, Dr. Kusuma Pokala, assistant professor of medicine at the University of Colorado, and she's going to talk about a technique that she's really helped pioneered and pushed at Colorado, which is endoscopic vacuum therapy for esophageal fistulas and leaks. So hand over to you, Dr. Pokala.
Thanks so much, Bilal, and thanks to everyone who stuck it out for our last session of RMIE this year. So let's get started. So I have nothing to disclose for this talk. Our learning objectives include to review methods of endoscopic management for esophageal fistulae, leaks, and perforations, to discuss outcomes of esophageal stents, to discuss outcomes of endoluminal vacuum therapy or EVT, and to discuss how to perform EVT. So I'd like to start off by talking about the definitions for various esophageal defects, as these terms are often used interchangeably but mean different things. So esophageal leaks refers to postoperative dehiscence in a perianastomotic area. Esophageal fistulae refers to communications between the esophagus and other structures, which can be caused by benign or malignant causes. And then there's esophageal perforations, which are transmural defects that can be spontaneous, such as in Boerhaave syndrome, or iatrogenic from endoscopy or surgery. So there's two large categories of endoscopic closure methods. These include primary closure methods that bring the edges of the defect together, which include clipping that can be done through the scope or over the scope, endoscopic suturing, which can also be done through the scope or over the scope, although the latter technique is more challenging in the esophagus, and then tissue ablation, which is often used as an adjunct therapy to clipping and suturing. We'll focus primarily on this talk on methods of secondary closure, which is the other large category of endoscopic closure methods. These techniques involve healing defects by secondary intention. They include esophageal stenting and esophageal vacuum therapy. So esophageal stenting was first described in the 1880s for the palliation of malignant dysphagia. The first stent was actually made of boxwood and silver and was successfully placed in 1885 for malignant dysphagia. Stenting can be performed with stents of a variety of different materials, including fully covered self-expanding metal stents, partially covered self-expanding metal stents, and plastic stents for the purpose of esophageal defects. And it's thought to work by working through a sealing effect, by sealing off the defect, which minimizes contamination and allows that area to heal by secondary intention. Esophageal stenting has high technical success rates. It's widely available. Its clinical success rates are variable depending on potentially the stent material used, the timing of stent placement, the type of defect you're trying to heal, as well as the defect size. Other factors that go into clinical success is length of stent duration. And then it's just important to note that there are stent migration rates that can vary from 10 to 40% depending on the material, and if you also use any anti-migration techniques like clipping or suturing. Endoluminal vacuum therapy really arose in the 2000s as an alternative therapy for esophageal defects. It's adapted from wound vacuum therapy for external wounds, and it was first described in 2007 for the treatment of post-surgical upper GI leaks after a patient who underwent esophagectomy and another patient who underwent gastrectomy. It involves attaching polyurethane foam to a nasogastric tube, which is then positioned over the area of the defect and placed to continuous negative pressure. It's thought to work by controlling the septic focus and secretions by providing that continuous internal drainage. That suction also stimulates granulation tissue, decreases bacterial contamination, and promotes perfusion in that tissue. These endoluminal vacuum devices or sponges can be placed intraluminally across the defect or extraluminally into a cavity that the defect is communicating with. So when you have a patient who's undergoing EVT, once you have that sponge in place, you can perform exchanges every 3. We've actually spaced ours out for a lot of patients to 7 days. And on average, it's taking these defects to heal in over 3 to 6 weeks. During that time, that device is placed to continuous negative pressure. There's a variety of different pressure ranges that are performed at different centers and reported in the literature. We put ours at 125 milligrams of mercury. During this period, patients are strictly NPO. And so we have to figure out other ways to provide them nutrition during that period, whether that's through enteral feeding or TPN as a bridge to enteral feeding. This table depicts outcomes of EVT based on reviews that have been performed over the past 10 years. Shows that the clinical success rates of EVT are high, above 85%. They tend to be higher for treatment of perforations over anastomotic leaks. The most common adverse event rates include stenosis, which is something we sometimes see during EVT therapy as it's being performed in between exchanges or in the time period after EVT has healed a defect and in that post kind of EVT period weeks to months later. The other adverse event that has been described is migration of the sponge. So probably the most important adverse event to know about with EVT is acute hemorrhage. And this is something that is typically seen when sponges are placed into a cavity or out of the esophageal lumen. And so the cases that have been described include a case of an aortoesophageal fistula that developed because the sponge was placed into a cavity that was in close proximity with the aorta, and the patient ended up dying from an aortoesophageal fistula. Another case that's been described is development of a right atrial pseudoaneurysm with a sponge that was placed in close proximity to the right atrium, which led to rupture and death. But overall, this complication is rare. It is recommended that if you are putting a sponge into a cavity outside of the esophageal lumen, to obtain a CT directly before or after that first placement of that sponge, just to make sure that it is not adjacent to any major cardiovascular structures. The other adverse events that we previously discussed include stricture development, which is usually treatable with endoscopic balloon dilation, as well as sponge migration. Sponge migration, we've typically seen more for GE junction defects, or sometimes with, we've treated a couple of duodenal perforations, and it's a little challenging to keep the sponge in that location, but we've tried clipping with sort of mixed results, something that we're still investigating. And then, something that hasn't really been described well in the literature, but definitely needs further evaluation, is that a lot of our patients have pretty poor quality of life during EVT therapy. They can't have anything by mouth. Their mouths are constantly dry. They have something sticking out of their nose. And I think this is just something important for us to recognize before we recommend EVT therapy to patients, and something to discuss with them as you're consenting patients to embark on this therapy. So how does EVT compare to esophageal stents? Well, these are all retrospective comparative studies comparing EVT to stenting for patients with esophageal defects. EVT consistently had higher rates of clinical success compared to stenting. Mortality rates were also consistently lower. Rates of stenosis was also described as being lower in one of these studies. There's variable statistical significance listed here for these outcomes, but our sample sizes are small. And unfortunately, we don't have any large prospective studies or any randomized control studies in this area. So in our lab, we have EVT kits ready to go. Our charge nurse, Lauren, makes these kits, and they contain polyurethane sponge, a ruler, a nasogastric tube. We use 14 French tubes, suture. We use 2O polypropylene suture, grasper, lubricant, a nasal transfer device, because we position our sponges initially through with the NG tube through the mouth, and then transfer that tube at the end of the procedure. Also include a bridle, scissors, hemostat, and tape. And then Lauren, our charge nurse, also made these great stickers in red here that we attach to our tube, so that our floor nurses know that this tube is not for feeding and should only be placed to suction. All right, so how do we create or attach the sponge? It's quite an easy process. So you want to cut your sponge to be sized according to your defect. I usually cut my sponges about 2 to 4 centimeters longer than the defect size, so that I have 1 to 2 centimeters of leeway above and below the defect. Once you cut your sponge, you want to tunnel through to create a little lumen so that your nasogastric tube slides through. You want to make sure that all the holes at the tip of your nasogastric tube are covered by the sponge. And so you cut any remaining excess tissue, but you don't want those holes to be directly providing that suction against the esophageal wall. And then once your sponge is positioned accordingly, then you suture in your sponge to the tube. And we typically do suture at the tip as well as on the more kind of proximal end of the sponge. And then we create 2 loops with that suture. The goal of that loop is that you have something to grasp with when you are advancing it through the oral cavity and into the esophagus and into the stomach. So that's the traditional endoluminal vacuum therapy device, but there's been modified EVTs that have been described. The left depicts a modified EVT made by applying first gauze, then antimicrobial drape to a fenestrated NG tube. And on the right is an open pore film drainage in which a NG tube is wrapped in a double layer of open pore drainage film. Both of these devices help provide vacuum therapy to smaller caliber areas for which placement of a standard sponge would be extremely challenging, or an area where the risk of migration might be extremely high. These modified systems also may allow for increased time between exchanges and may actually be more cost effective. So I'd just like to show you guys a couple cases that we've done. For the first case, we have a 56-year-old gentleman with a history of polysubstance abuse who presented to an outside hospital with Boerhaave syndrome. An EGD was performed there and found a 25 millimeter defect in the lower esophagus. He initially underwent stent placement there, and then with a fully covered self-expanding metal stent. He had poor control of his defect and was actually transferred here from that outside hospital. He underwent VATS, and there was persistent concern that that defect wasn't contained. So he underwent an overlapping stent placement. He had chest tubes in that were continuing to have bilious output. So we removed those stents and this is the exam that we did. He had a large defect extending from the distal esophagus just across the GE junction. It was about 4 centimeters in size. This is the retroflexion view of that same defect. So we decided that we would put in a sponge. And so this was a 4 centimeter defect, made an 8 centimeter sponge so that we would have 2 centimeters above and below. I typically like to make my sponge width about 3 centimeters for esophageal defects. So we did that, and then here I am advancing the sponge into the stomach. That's the grasper there on that loop of suture. We let that suture go. And there's that, you can see the distal aspect of that sponge there. Bring the endoscope back up into the esophageal lumen, and then drag that sponge into the area of the defect. And it's coming, I promise. All right, there it is. So once it's in place, then you bring your endoscope out, you do your nasal transfer, and then bring them back for a sponge exchange. That patient's actually still undergoing his sponge exchanges, so I wasn't able to show you his final resolved defect. But case number 2 is someone who underwent a laparoscopic hiatal hernia repair that had a distal esophageal perforation. The index EGD reveals a defect that's pointed out by that arrow on the left. It's communicating with this large cavity that you can see on the right. This patient underwent initially stent placement, and then imaging showed a persistent defect, underwent an overlapping stent, still persistent defect. And so the stents were removed 10 days later. And that blue arrow points to the area of the defect, which is kind of covered in a lot of pus. And then this is a kind of a blown in version of that. We put a sponge in. This was at the first exchange. That area is already looking better. There's more granulation tissue there. And after 3 exchanges, that defect is completely resolved. The last case I wanted to show you is a gentleman who underwent distal esophagectomy for esophageal adenocarcinoma at the anastomosis, he developed evidence of an anastomotic leak on post-op day 11. At his index EGD, he had this large defect at the anastomosis. You could see the staples there, and it's connecting to a large cavity. So an partially intracavitary sponge was placed. And after 4 exchanges, this is that resolved cavity. There's no visualization or communication with any other surrounding structures. So in summary, endoluminal vacuum therapy has high clinical success rates and low adverse event rate for anastomotic leaks and esophageal perforations. Large multi-center prospective studies, though, are needed, as well as randomized control studies to evaluate the use of EVT for the treatment of these esophageal defects. Thank you. All right, can you hear me? So I'd like to introduce my colleague, Mohammed Bilal, up to the microphone. He'll be giving us our next talk. I think the title of his talk is maybe the best of our MIE this year. So I'll hand it over.
Thank you so much, Kusuma, and thanks for an excellent presentation. Full disclosure, I didn't come up with this clever title. It was Dr. Wani, Dr. Shah who came up with this title. So I'm going to talk about POEM, all different types of POEM and myotomies in the next 15 minutes. And so it's going to be a quick overview, and happy to take any questions afterwards. So first, we're going to talk about achalasia. Obviously, we know that achalasia is a progressive disease which involves neurodegenerative motility issues, and the hallmarks are lack of peristalsis and lower esophageal sphincter relaxation. Diagnosis, obviously, endoscopy. As GI doctors, we see them a lot of times. These patients have been misdiagnosed with GERD for many years, and then eventually we'll get an endoscopy where we'll see pooling of secretions, tight LES, hypertonic, and then obviously esophagogram. And then we do, obviously do esophageal manometry for these, and that's really important because it tries to help differentiate the different types of achalasia. And I'm going to briefly touch upon that, why that's important, because what intervention you're doing varies and tailors based on the type of achalasia. Before we had a lot of advances in endoscopy, we obviously would rely first on pharmacological therapies. None of them work great, but can help with some motility symptoms at least. Endoscopically, we relied on pneumatic dilations and Botox injections to the LES, and then surgery, Heller myotomy, which has the highest success in type 2 achalasia. And then about almost 15 years ago or so, or 14 years ago, POEM, pearl endoscopic myotomy, which you saw a demonstration yesterday, came into view. We have really high quality data in the form of randomized controlled trials now for POEM. So this was an article published in New England Journal of Medicine a few years ago, looking at endoscopic or surgical myotomy in patients with idiopathic achalasia, and this was a non-inferiority study, including over 100 patients in both arms with Heller's myotomy and POEM, and clinical success was equal. So it was in both of them. POEM was non-inferior to a laparoscopic Heller's myotomy. The reflux esophagitis was higher in the POEM group as compared to laparoscopic Heller myotomy. POEM, as we've already kind of understood by now, is minimally invasive. The benefits are it's a rapid recovery. These patients go home the next day, or a lot of institutions even the same day. It allows you the ability to tailor the length of myotomy, which is really helpful in type 3 achalasia. You can tailor it according to the spastic segment or jackhammer esophagus. It's durable. The serious adverse events are lower, but the risk of reflux is there. The risk of clinically significant reflux where patients need to have another endoscopic or surgical intervention may be low, but it's a really important thing to talk about with the patient. So who's a good candidate for POEM? Certainly people with type 3 achalasia who've had a prior Heller myotomy because they can't get a repeat, if they've had prior obesity surgery, because those are challenging surgically to do. People who are not a great candidate for POEM are those obviously who can't tolerate anesthesia or have coagulopathy, don't want to be on the long-term PPI, or have gastroparesis. So putting it all together, this meta-analysis published in Lancet looking at POEM, laparoscopic Heller myotomy, and pneumatic dilation, basically summarizes that both POEM and Heller myotomy are more effective than pneumatic dilation. Neither POEM or Heller is more effective than the other. Pneumatic dilation was significantly less likely to have adverse events, but Heller myotomy was the one to have the least amount of reflux. But POEM was the least likely to lead to perforation, need for surgery, serious adverse events, and need for reintervention. Briefly, I know we're going over multiple video demonstrations yesterday, but you saw steps of the POEM. You can see our hypertonic LES. We do a mucosal incision a few centimeters above the where you want to start the myotomy, and then you do make a tunnel in the submucosal space, and using continuous dissection and injection, you tunnel all the way to the gastric cardia, and then we do a myotomy. So this is a demonstration of a POEM I did a few weeks ago. So here you'll see a hypertonic LES prior to initiation of the procedure. And then we decided to proceed with POEM. As I mentioned yesterday in our demonstration, that we have now, for disease only at the LES for type 1 and type 2, we have sort of converted majorly to a tailored short myotomy, which is about 5 to 6 centimeter, 3 to 4 centimeter in the esophagus, and then 2 centimeter into the gastric cardia. And here you can see we're doing tunneling. And as we discussed yesterday, the key in POEM, opposite of ESD, is that we want to stay close to the muscular propria, because you're going to eventually cut the muscle anyways. And really the goal is to preserve the mucosal integrity, because that's really what's considered a true perforation. So here you'll see we'll tunnel all the way to the gastric cardia. And as you saw yesterday, you see a really tight high pressure zone, and then you see this larger area, which then you're in the cardia. But we confirm on 3 different ways, as I said yesterday. Then here you'll see we're doing a selective circular myotomy to start, and you'll see the splitting of the longitudinal muscle fibers, and we're just dissecting the circular muscles. And then as you get close to the LES, there's a debate whether you do a full thickness myotomy or continue with a circular myotomy. But everybody believes that leaving any circular muscles behind will lead to recurrent or residual achalasia. Once the myotomy is done, we can close the mucosal incision. We'll inspect. Typically, you'll see our wide open lower esophageal sphincter. Come back, make sure the mucosal integrity is there, and then perform clip closure. Typically that results in really good. We keep the patients do an esophagogram sometimes the same day or the next day, depending upon individual circumstances. This is the case from yesterday. We couldn't show this on camera, but I know Dr. Gabriela, but he's in the room with us. So after we finished the myotomy, we have now incorporated EndoFlip in our practice. And part of that, there's two reasons for that. One is that because we're doing tailored short myotomies, that's significantly reduced our procedure times, but we want to make sure that we're not leaving residual disease behind. So intraoperative EndoFlip prior to closure allows us. So this patient's DI from yesterday, if you remember, was 0.5, and this was a distensibility index after POEM was 3.3, and the diameter was 5.6, and now it's 15. So very nice result before we did the closure. The other reason we're doing this is that our site is going to be part of the Primidia randomized control trial as part of our esophageal center. And that trial is led by Northwestern and is going to compare tailored short and long myotomy, comparing the risk of reflux. So obviously for a lot of our colleagues in the audience who refer patients to us, this will be starting hopefully soon once the NIH sends an award. So we'll switch now, Garris, to gastric pearl endoscopic myotomy. Again, you saw an excellent demonstration from Dr. Messman about that. This is a little bit more tricky because patient selection is critical because not all patients with gastroparesis should get a GPOM right off the bat. And patient selection really plays a role in your outcomes. So we obviously follow the ACG guidelines for this algorithm. A lot of these patients have seen our dietitian, they've gotten pharmacological interventions. And then really this is when you really want to focus on, as Dr. Christie always says in her gastroparesis talks, is you want to open the gate. So that's what, it's not going to fix the motility of the stomach. It's only going to allow the pylorus to open. So that's when we do these procedures. As much as I love being in the third space, this is one procedure where, a lot of the patients who see me end up not doing this when we really go over the outcomes. But there is now starting to get some good high quality data. This randomized control trial that was published in Gut with just 41 patients with gastroparesis showed 71% improvement with GPOM versus sham and 75% improvement in the crossover group. And the gastric emptying study does improve after GPOM. Just as you saw yesterday, we start about 4 to 5 centimeters proximal to the pylorus. I use a greater curvature approach. I know we discussed that yesterday, greater versus lesser curvature. And then here you'll see we're making trying to get into the tunnel. Once we get into the tunnel, just like in POEM, we try to stay really close to the muscle because you want to again preserve the integrity. The really critical part, if you're going to offer this procedure, is that you really do want to cut the pylorus, and identifying the pyloric ring is really important. And there are two ways that we look at it. You typically see this little waterfall here, as you can see, and the pyloric ring is right underneath it, and it looks like some people tell me it looks like a fried calamari. I'm still not bought on that. But and then you do a myotomy. Sometimes you can do a single versus double myotomy, but there's no data behind that. If you do a longitudinal incision like Dr. Messman did, you can close it with clips. And if you do a transverse incision like I did, I typically will suture it. Here you'll see a patent pylorus after performing GPOM. Switching gears to Zenker's diverticulum, as a gastroenterologist managing dysphagia, we do see patients who end up with Zenker's diverticulum. It is the most common esophageal diverticulum, but it is overall pretty rare. It's a outpouching of the pharyngeal mucosa, and patients can present with dysphagia, choking, halitosis, aspiration. Classically, this was a surgically managed disease where they got either a diverticular suspension followed by myotomy or a surgical diverticulotomy. But now endoscopy over the last few years has a role for this. I love the schematic from our very own Dr. Ryan Law that he published in CGH on how this works. As when you have a Zenker's, basically your Zenker's lumen is much bigger than your esophageal lumen. But once you do a diverticulotomy or a myotomy, then the hope is that the esophageal lumen, the Zenker's will flatten out and the esophageal lumen will get bigger. That's how this concept works. There are two ways you can approach this endoscopically. There's a Z-POEM or a Zenker's POEM, or there is a flexible endoscopic septotomy. This meta-analysis shows that more or less they're both similar in terms of efficacy. There's a little bit of higher clinical success for for Z-POEM, but no difference in recurrence, adverse events, procedure time, and length of stay. So this is a Zenker's diverticulotomy that you're doing. There's a very thick septum, but a small diverticulum, but the patient is really symptomatic. Actually, a lot of our referrals come from ENT because it's hard for them to operate without a flexible scope in this tight space. So I typically will leave a wire in the true lumen, especially when they're short diverticulums like this, so I know where the esophagus proper is and where the diverticulum is. And using a scissors type electrosurgical knife, you basically make a little mucosal incision and keep expanding your mucosotomy till you start seeing the cricopharyngeus muscle. And in this case, the length of the diverticulum is pretty small. It's actually the how bulky and thick the septum actually is. So once you get exposure to the cricopharyngeus muscle, as you'll see here in 1 second. Really nice exposure to the cricopharyngeus muscle, and then you can really just do a myotomy and dissect all the way. I kind of do this like modified approach in the middle, where I have our nursing colleagues open the knife just a little bit, so I get into sort of this sort of tunnel, and then try to keep doing a myotomy till I get to the buccopharyngeal fascia. And then when you get to the buccopharyngeal fascia, you'll see this really glistening fibers. It's kind of hard to miss. A lot of times patients will develop some neck swelling and crepitus, but that typically resolves immediately after the procedure. We use low carbon dioxide for all these third space endoscopy procedures. And then in the end, if I feel like there's still a little pouch left, I will do what we call as a shaping of the septum and do a little expand the mucosal incision on that side. The other technique is what we discussed as Z-POM, which includes the tunneling and the incision parts of this procedure. This is a video from one of my dear friends and colleagues, Tom Tillman at Southwestern. And here you'll see you basically create a mucosal incision, tunnel on both sides, the esophageal side and the Zenker side, expose similarly like we did in the septotomy, expose the cricopharyngeus muscle, and then you can do a myotomy. He's using a scissors type knife, but you can really use any electrosurgical knife that you're comfortable with. And then incision is small, so we like to use really short stem clips because it's pretty high up. And here you'll see that once this is done, he'll finish it up with a few clips. And same thing, some centers send the patient home. Some people do an esophagogram next day to make sure, the same day to make sure before discharging the patient. The next is a D-POM or a diverticular POM, where if there is a true esophageal diverticulum, you could create a similar approach like we do in the Zenkers in the esophagus, and again, tunnel both sides of the diverticulum and then do a myotomy. So we do have occasional patients here who don't have achalasia, but do end up having large esophageal diverticulums. So we worked with our two excellent motility colleagues, Dr. Menard Catcher and Dr. DeLay, and work closely and decide these patients. Lastly, we use the submucosal tunnel endoscopic resection technique for doing procedures. So this is a medium-sized gist for a patient who did not want surgery and didn't want to continue endoscopic surveillance. So you use the same principles of endoscopic tunneling. So you'll see we'll make a mucosal incision, and now we're in the tunnel. But in this case, you have to actually do a full thickness resection inside the tunnel. So here you'll see I've actually cut a little bit of the serosa, and here you'll see the liver popping up in view. Once you see that, sometimes it can be associated with abdominal distension. So we use a 16 gauge angiocath or a decompression needle to just expulse all the air out, and then you can continue and finish up your procedure. So here you'll see that we have the needle in place. Once the needle in place, then the rest of the sheath is pretty blunt, so you can leave it in, air is coming out, the patient's peak elevated pressures go down, and we can just finish the procedure. It's rare that we have to do that, but once in a while, and in the stirred procedure, if you cut a little deep in the serosa, you may have to remove the air. So here I'm just finishing the last bits of the resection of this GIST tumor, and you'll see here that this is the last fiber we're cutting. We remove this gist, and then you can see this really nice unblock resection of the gist, and then we can suture it or close it, whatever technique you prefer. In my case, in this case, we just sutured it. So I know this was kind of a quick fire 15-minute overview of a lot of myotomy. I want to thank, this is the picture of the day I did my first poem 3 years ago when I was in Minnesota. One of my mentors, Sunil and me and friends from Miami came, and actually 2 of my nurses who were there actually flew out for the nursing course, are sitting in the audience. So a big shout out to them for coming all the way from Minnesota to attend our Rocky Mountain Interventional Endoscopy nursing course. And of course, thank you to our incredible team here in Colorado who over the last 10 months have accepted me as a part of their family. And here you'll see pictures of nurses and our team, and anything is not possible without a team. So I'm really grateful to be here and happy to take any questions at the end. Thank you so much.
Thanks, Bilal. That was fantastic. Next up, we have Jennifer Fan, who is Medical Director for the Hoag Irvine Advanced Endoscopy Center, as well as Director of Bariatric Endoscopy and Program Director of the Advanced Endoscopy Fellowship at Hoag. We saw her perform a beautiful Barrett's EMR yesterday, as well as a TOR procedure, and today she'll talk to us further about the state of bariatric endoscopy.
Awesome. Thank you so much. And thank you again to the course directors. All right. So bariatric endoscopy, it's a very exciting time for bariatric endoscopy, especially honestly in the last week and a half. So we'll kind of go through why. So obesity trends nationwide are quite alarming. So in 2019, over 35% of patients in the middle of America are identified as obese. That rate in 2033 is even more alarming. What we know is over half of Americans will be considered obese by 2030. Half of children will start to be obese by 2050. So this trend is not going away. And why is obesity so important for us is because there are things that are related to obesity that we eventually have to treat. Non-alcoholic fatty liver disease, or now known as MASLD or MASH, infertility, various cancers, for us colon cancer, esophagus, and pancreas cancer are related to obesity, and obviously coronary disease and diabetes. What we know, though, is we don't need radical amounts of weight loss in order to get health benefits. And I think the push of the bariatric endoscopy societies are to really focus on obesity-related comorbidities. It's not the weight loss, it's the fact that we can alter outcomes of your obesity-related comorbidities. So what we know is that 3% total body weight loss can affect your blood glucose and triglyceride levels. 5% we start to see improvements in your lipid panel and your blood pressure measurements and steatosis by MR, and then measuring the feelings of function. Remember, quality of life is a big issue for patients with obesity. So even losing just a little bit of weight can really help quality of life. All of our outcomes for obesity-related interventions must meet a 10% total body weight loss threshold to be considered effective therapy. So at 10% total body weight loss, we start to see the NASH activity score improve based on liver biopsies. Sleep apnea starts to improve. And at the 15% total body weight loss, we start to see improvements in cardiovascular risk, mortality, and remission of type 2 diabetes. When we used to talk about obesity, we used to use kind of this graph where weight loss and invasiveness of therapy. And we know that all 4 options are fantastic for patients, right? Lifestyle, medications, bariatric endoscopy, and bariatric surgery. Bariatric surgery, I'm a huge fan of, but unfortunately, this has not changed in the last 20 years, that only 1% of patients who qualify for bariatric surgery will get bariatric surgery. What markedly has changed has been the medications, right? We used to think that medications were less effective than bariatric surgery. What we know is that all these medications are starting to come towards the effectiveness of bariatric surgery. We have retatrutide coming out. That's a triple agonist that in current studies, in phase 2 studies, looks like it has 25 to 28% body weight loss in 6 to 12 months. That puts it at par as a sleeve gastrectomy and a Roux-en-Y gastric bypass. For a multidisciplinary approach to therapy, we used to think that patients should progress linearly across this lifestyle, these options. But what we know is in a good multidisciplinary setting and an approach for obesity, patients will jump back and forth across, and in addition to multiple areas of multiple options. So the thing that I get questioned the most is GLP-1s, and all the different versions of the GLP-1s are fantastic. So what are the possible roles left for bariatric endoscopy and bariatric surgery? What we all say is that GLP-1s did us a great service. It took obesity and made it into a disease that patients thought needed to be treated. right? So it made people think, you know what, I need to take medications because I have obesity. This is something I can treat. It opened the door for patients with obesity to come into the space of therapeutics. And what we know is that GLP-1s have a significant limitation in terms of access and side effect profile. So a survey coming out of Europe where most patients get their GLP-1s via cash pay, but that cash pay price is less than a tenth of what it is in America, there is still a significant dropout of patients because of access and ability to afford GLP-1s. So unless the GLP-1s can drop down to less than $100 a month, these are still considered unaffordable medications for most patients. Then we have the fact that a close second to that is the drop-off related to GI side effects. So really, there are a lot of options here for patients who initially walk through the door via GLP-1s, but may either need to come off GLP-1 therapy for either a variety of reasons. So for endoscopic weight loss procedures, our mainstay procedure is the endoscopic sleeve gastroplasty. So it's an outpatient endoscopic procedure, 45 minutes. I rarely admit patients. I only admit my patients who are on dialysis or who are cirrhotic with non-significant portal hypertension. And mostly that's related to the fact that end-stage renal patients and cirrhotic patients can't take a lot of volume. And we want to be able to really hydrate these patients before they go home since they're not taking in that much oral volume in the first 48 hours. We aim for a gastric volume reduction of around 70% using full thickness suture plications and gastric tunnelization. This is the randomized controlled trial that randomized patients from ESG to lifestyle called the MERIT trial. And at the 52-week follow-up, patients were able to cross over if they were put into the lifestyle arm. And what we see that despite being done in the middle of COVID, we saw a significant percent total body weight loss of around 14%, with 77% of patients achieving an excess weight loss of over 25%. The difference mainly between ESG and a sleeve gastrectomy is that the chance of reflux is significantly worse and significantly better. And we see that in the fact that patients who underwent ESG had a reduction in GERD and there was no new worsening GERD. So a previous study showed that in patients receiving a sleeve gastrectomy, up to 14% may get reflux requiring lifelong medication. That rate is significantly reduced in ESG to only around 7%. ESG has also been shown to have improvements in diabetes indices and HOMA-IR scores. And then the below bar graph shows that it also has a role in decreasing the rate of fibrosis in patients with liver disease. So what this shows is that at baseline, we have a significant portion of patients in the indeterminate to F3, F4 category. And after a 52-week follow-up, after a gastric remodeling procedure, patients then moved away from the F3, F4, more into the indeterminate F0, F2, so we can actually reverse some level of steatosis and fibrosis. I'll keep the video playing here, and what we see here is the first suture pattern, which is an eye pattern. And what we're creating here is going to be the new kind of pylorus area. And so it's the area of the incisura that's now significantly reduced in volume. And that is the most important suture that we place is this first suture. So it's really important to set the stage in the background for volume reduction based on the first eye suture along the angularis. I'll continue. Oh, I'm hoping this will continue to play. ESG has long-term studies showing benefits in BMI, weight and waist circumference, hemoglobin A1C, triglyceride levels, blood pressure, systolic blood pressure levels, ALT, portal pressure measurements, degree of hepatic steatosis, and reflux symptoms. And what we know is that ESG is effective. So total body weight loss at 6 to 12 months is around 15 to 18% nationally, an adverse events rate of 1 to 3%, usually related to pain, nausea, and vomiting. I tell patients that I don't quite apologize if they have nausea, pain, and vomiting after the procedure. It's a highly inflammatory procedure, but innately after 48 hours after the inflammation has calmed down, you have significant reduction in those symptoms. You'll see here on the left that this is what the final tunnel looks like, a significantly reduced gastric volume, very similar to what you would see with a sleeve gastrectomy. So when to consider this for patients. So patient preference is a huge thing. A lot of patients are coming very interested in these procedures because it is a outpatient procedure with a 2-day recovery. Patients who are not responding to anti-obesity medications, and ineffective response is defined by a less than 5% total body weight loss in 3 months. Those that cannot tolerate AOMs, mostly related to GI side effects, or are looking for an alternative to come off their AOMs. There are also patients that need to be on AOMs but are requiring additional therapy in order to get effective weight loss. So these are your patients with a high BMI of over 45 that may not be able to ever get down to the low 30s or high 20s just on AOMs, that they need a secondary procedure with it. Patients that are on immunosuppression, steroids, and blood thinners that can be held are good candidates, and those that have contraindications to bariatric surgery. The exciting thing is, and this is a good example of how clinical medicine and clinical physicians can work with industry in order to achieve the next steps that are beneficial for patients. So we got first news of exciting coverage, a national insurer coverage for ESG for patients with a BMI over 35, or those that have a BMI of 30 to 35 with at least one significant comorbidity. It's important to realize that we actually don't have studies for a lot of these comorbid outcomes in terms of ESG adding benefit to that. They're a presumed benefit. So if any fellows there want to do research within this space, we technically don't have studies looking specifically at OSA and specifically at CAD. There's about to be one study published about 10-year CAD risk benefit secondary to ESG, but that is the first study to come out looking at cardiovascular benefit with ESG. So lots of work to be done here, but important nonetheless that the biggest barrier to patients getting ESG has now been overcome because of this industry and physician partnership. The transoral outlet reduction, we saw this yesterday. So a lot of movement has been to push it more towards an ESD TORI. So yesterday we did APC because the outlet was so big that the lumen was completely effaced out because of how big the stoma was. But innately, if there's a rim around the GJ stoma, then it's nice to do a almost circumferential ESD. I also leave kind of that runway free, and you'll see that here kind of on this side here is that outlet area towards the where the efferentijunal limb is. I leave that open because I want everything to kind of come up towards that space. And ESD is done almost circumferentially, and then I use an APC to take away any kind of healthy mucosal tissue that may be in the way. Then using a zipper pattern, first described by Barma Budaya, we'll zipper pattern up and then decrease the outlet down to around 6 millimeters. A TORI is a great option for patients who've had weight regain with a room-wide gastric bypass, again with a dilated stoma over 2 centimeters or a pouch elongation, anything over 4 to 5 centimeters, and can be done in conjunction with medical therapy, and especially those who want to taper off medications. And so we have a lot of patients in my clinic that are coming off Mounjaro and using a TORI in order to continue their weight loss. So remember, when we come off GLP-1s, there's a V-shaped rate regain and a regain of obesity-related comorbidities with it. And so by doing a TORI as they're coming off their GLP-1s, we can keep all of those things that they had gained while on their GLP-1 at bay. In terms of the TORI, it's effective. The old way we used to do a TORI had a total body weight loss of around 8 to 12%. Adding the ESD portion on top of it is around 12 to 16%. Adding the ESD with the zipper pattern, we hope to publish what gets us closer to around 18% with a TORI. Safe and effective, and then if patients need repeat procedures as needed, then it's possible to be offered. There are additional endoscopic procedures that are undergoing active clinical trials. So the POSE is a serosal to serosal apposition that has been done primarily out of the group of the Brighams, currently with the initiation of a randomized multi-center trial to evaluate this modality as a way for gastric glycation. The BEAM, or bariatric endoscopic antromyotomy, also coming out of the Brighams, was really to evaluate the transpyloric shuttle system and to decrease gastric emptying, showing also a significant weight reduction. And then this gastric fundoablation, so ablating the fundic tissue, is really being done by the group out of Mayo and Chris McGowan's group. Trial data is underway. And very briefly, I wanted to touch on metabolic endoscopy because this is innately kind of the biggest thing that is happening in the world of weight loss and metabolics. And so what if a single endoscopic procedure can help you with your type 2 diabetes? And what we see is that when patients have room-wide gastric bypass, you get improvement in markers in your type 2 diabetes, whether that be via the hindgut or the foregut, a way of looking at things, whether it's the exclusion of the small bowel, modifications of the GLP-1 PYY hormones, or whether it's this foregut hypothesis that you're preventing excretion of putative signaling, something happens where the small bowel changes and diabetes gets better. And so what we see in patients with normal duodenums is that you have your incretins here that communicate with your brain, liver, pancreas, and stomach, and you control your blood glucose. But in patients with diabetic duodenopathy, there may be an increase in hyperplasia and dysfunction within the duodenum. There is dysregulated communication with the brain, the liver, the pancreas, and the stomach, and now you have uncontrolled blood glucose. And so there are 3 different types of metabolic therapy, and we were lucky at Hoag to be able to be a part of all, or going to be a part of all 3. There is hydrothermal ablation therapy that was shown to decreased hemoglobin A1C by around 0.8% after one therapy. There's electroporation therapy using electrical signaling across the duodenum, being able to really penetrate through into the submucosa, into the muscularis propria, where 12-week follow-up after a single electroporation treatment showed a decrease of hemoglobin A1C of 1.5%. This is the only active clinical trial going on. Hydrothermal therapy did pivot their trial to an obesity-centric trial instead of a type 2 diabetes trial. And then the last type of therapy is vapor therapy. So with a single through-the-scope device, being able to put steam into the small intestine, the initial studies showed a decrease of hemoglobin A1C of 0.8%, but at DDW they showed evidence showing that they could actually get the vapor all the way deep into the jejunum, and by doing that, they were able to decrease the hemoglobin A1C of up to 2% by one procedure. So currently, that's all being done in Chile, but there are 5 centers in the United States that are waiting for IDE FDA approval for us to start this clinical trial here using vapor therapy. And so again, the only clinical trial currently available for type 2 diabetes is via electroporation. And what we see is it's a fluoroscopically a wire-guided technology that goes into the duodenum beyond the ampulla, being able to treat around 9 to 11 centimeters of the small intestine. And what we see is that biopsies of untreated controls, there's lots of inflammation, the stem cells are not adequately homogeneous across all the villi. 1 hour after treatment, we start to see some reorganization, but 4 weeks after treatment, we start to see that healthy villus architecture that is similar to what we see in non-diabetic duodenums. And so with that, I'll end and say that it's a very exciting time for bariatric and metabolic endoscopy. Lots of primary revisional therapeutic options that are available with multi-center trials underway. And metabolic therapy, we currently have 3 possible duodenal resurfacing technologies, 2 of which will be undergoing randomized controlled trials. And I can't end this enough without saying that this is one of the only procedures we'll talk about today where technical success does not equal clinical success. Bilal can do a poem and 100% of his patients will have clinical success. This technology and technique to do a bariatric endoscopy is not that hard, but it's the only time where if you do not have a multidisciplinary group around you, you can be the best suturer known to mankind, but you may only get 25% of your patients to achieve the weight loss that is rightfully necessary for these procedures. So it's been a huge push for us in this field to say, please do not do these procedures unless if you don't have dietitians, endocrinologists, and a very good following, because technical success does not equal clinical success. So with that, thank you so much.
Thanks so much, Jennifer. Next, we have our debate on the management of gastric outlet obstruction. Dr. Kenneth Ben-Muller will be arguing in favor of EUS GJs, and he'll start us off. He's really someone that we've heard a lot from today, and really needs no further introduction. So go ahead.
Thank you so much. And again, what an amazing course. Really jam-packed with so much education, a true marathon spanning the entire spectrum, including the treatment of metabolic disease. So I'm so happy and grateful for the opportunity to participate. It's no surprise, of course, that I'm asked to argue, but I don't like that term. I would rather say that I would like to just represent my experience with EOS GJ, which has been found to be very effective across many centers. How do I advance here? Okay, good. So 1992, Dick Kozarek, he actually described the first SEMS for malignant gastric outlet obstruction, and he used something called the Z stent. It was actually developed at the center where I did my fellowship, Oregon Health Sciences University. Charles Daughter is the father of SEMS. He invented the self-expandable metal stent back in 1969. And then one of his pupils, Joseph Roche, teamed up with Cesar Gianturco. He's an engineer, and they developed the Z-stent. So that was the very first SEMS, and it was first placed in the esophagus. As a fellow, I was able to do the first experiments in pigs, placing the Z-stent, which I constructed together with engineers at the Charles Daughter Institute at Oregon Health Science University. So this really brings back fond memories for me that the very first SEMS for malignant gastric outlet obstruction was performed by Dick Kozarek in the duodenum. But at that time, and look at how this is, I have a pointer here, look at how he titled this paper. So he's describing this first experience, but he is stating caveats and concerns. And his caveats and concerns are tumor in and overgrowth that he had observed, migration risk, and perforation risk due to a rigid delivery system. And now we fast forward over 3 decades later, and we have this publication that looked at MAUD reports. So this is the FDA database. This is voluntary reports of complications from duodenal SEMS placement. And you see here a 12% rate of perforation, 8% rate of obstruction, and there's bleeding and 3% cholangitis, pancreatitis, because we can, of course, block outflow of the bile and pancreatic ducts. So this is very telling. This is resonating on the caveats and concerns. And then we have this randomized controlled trial. It's called the SUSTENT study. It's a small study, admittedly, but it had very decisive results that were compelling. And surgical gastroenterostomy was significantly superior to SEMS in terms of major complications, 0 for surgery versus 6 using SEMS, reobstruction 1 versus 8, reintervention 2 versus 10, survival 72 days versus 50 days. And the conclusion is that the surgical gastrojejunostomy was associated with better long-term results and is therefore the treatment of choice in patients with a life expectancy of 2 months or longer. And this is a case from just last week that came to me. This is a patient in whom in an outside hospital, a uncovered SEMS had been placed in the duodenum just 4 weeks earlier for a duodenal malignancy. And here I am going into the interior of the SEMS, and you can see this very impressive ingrowth. In fact, I couldn't even get my gastroscope, a diagnostic gastroscope, to traverse this stenosis that had recurred as a result of this very impressive ingrowth. And this is another case also from last week, so it was very timely for this talk. This is a patient who had had a covered SEMS placed for duodenal obstruction, and this had migrated down into the ileum, was sent to us in the hopes that we could retrieve this from the ileum, but unfortunately we were not able to get to it, and this patient ended up having to go to surgery. So here we see the guidelines, the AGA guidelines, best practice advice, number 6, for patients with gastric outlet obstruction who have a life expectancy more than 2 months, have good functional status, and are surgically fit, surgical GJ should be considered. And then we have the ASGE guidelines for malignant gastroduodenal obstruction in patients with a life expectancy longer than 6 months, good performance status. We suggest a surgical GJ compared with SEM. So they're extending this a little longer to 6 months. But basically, in patients who are felt to be extremely frail and more or less bedbound, then yes, a SEMS. Otherwise, send for a surgical GJ. So why do most of these patients end up getting duodenal stents? Well, it's because survival is difficult to predict. It's hard to say, whether they're really going to live longer than 2 months. And surgery does entail a long post-op recovery with delays, many delays in feeding, delay in cancer treatment, and a delay in discharge. And this all translates to a worsened quality of life. So with the duodenal stents, at least short term, we can offer an improvement in quality of life. But it inspired me as I was seeing that these patients are indeed living longer with all the advances we're making in oncology for the treatment of malignancy. If we could create an endoscopic gastroenterostomy, could that address the limitations of, or at least the reasons why patients still would prefer an endoscopic treatment? That inspired me to develop the LAMS. And so you can see the first study in 2012, where we did a hot puncture into the small bowel, deployed the distal anchor, proximal anchor. It's the first time that I'm looking at the afferent and efferent limbs in this pig model. And then afterwards, with necropsy, you can see this anastomosis that we had created. So this was, for me at least, the first time that I realized we could indeed create an endoscopic anastomosis. But the challenge of creating an EOS gastroenterostomy was that we're dealing with an organ that is extremely mobile and it's non-adherent. There's vigorous peristalsis. It displaces easily. So we needed a one device delivery system. We couldn't use the Seldinger technique with guide wire and dilate the tract. By that time, the small bowel would have moved away from the gastric wall. So we needed a one device hot delivery system. And so this is actually the first prototype that we developed here. You can see different prototypes. And this is the very first video in the pig lab that I'd like to share with you. So here we're using one of these first prototypes. We're able to get in with one step puncture, one device puncture really. And fortunately, it's not showing very well that we deploy the distal. This is an old video, obviously, from 2012, the distal flange and then the proximal flange. And this is how it looked in the pig model. So this, again, it's hard for you to feel the excitement that I felt back then because you've seen this now so many times at all the meetings. It's disseminated. But this was truly incredible to be able to see the afferent and efferent limbs that we had created endoscopically. This then evolved to the electrocautery enhanced delivery system where we had created, embedded these micro wires here that converge at the tip with a very hard ceramic bougie-shaped nose cone to facilitate the entry into the small bowel. So it was really about our ability to get into the small bowel without displacing it and minimizing any risk of leak. And so these steps are all familiar to you now. So now we have studies that have compared an EUS gastroenterostomy versus a duodenal SEMS. And we have this study from 2012, propensity matched. This was a multi-center trial from Europe showing that there was significantly higher stent survival in those patients who underwent the LAMS placement. significantly superior to the SEMS, duodenal SEMS, in terms of clinical success and stent survival. The dysfunction rate, 1% versus 26% using the duodenal SEMS. EUSGE was equivalent to SEMS in terms of adverse events, 10% versus 21%, so double the adverse, but still not statistically significant. However, there was an intraperitoneal maldeployment of the lambs in 3 patients, 3.4%, and these patients did have to go to salvage surgery, and so that really deserves mention. So now we have randomized controlled, the first randomized controlled trial. This is the DRAGU trial. This is a seminal paper, a multi-center trial from Asia. And it also showed that EUSGE was significantly superior to SEMS at 1-month gastroesophageal obstruction symptom score and 6-month reintervention rate and equivalency in terms of patency and survival. So now we're getting real science, evidence-based medicine to support EUSGE as being superior to a duodenal SEMS. And then we have this meta-analysis, 10 studies over almost 1,300 patients here with gastric outlet obstruction. Again, EUSGE superior to SEMS, clinical success, reintervention, adverse events. You can see here from the paper, reintervention rate, adverse. Those are the key parameters that we look at. Equivalency in terms of technical success, that's not surprising, and hospital stay. And then we have now emerging studies comparing EUSGE versus surgery. So surgical GJ, first the propensity matched studies from 2021 showing EUSGE superior to surgery in terms of procedure time. That's not surprising, of course. Time to oral intake, that's important, 1 day versus 3 days. We're seeing that now in the latest randomized controlled trials that I'll show you in a moment. Hospital stay, severe adverse events, and equivalency to surgery in terms of technical and clinical success. And this was really the highlight of DDW, I think, at least for me, to see these 2 randomized controlled trials comparing EUSGE versus surgery. This is the study, the multi-center from the Florida group. And this study, 74 patients. This is US and European centers. EUSGE superior to surgery in terms of a solid oral intake at the time of discharge, and a reintervention or need for supplemental nutrition and quality of life, specifically nausea and vomiting at 6 months, significantly superior in the EUSGE group, and costs, significant savings, and then equivalency in terms of adverse events. And then this is this study from Amsterdam, Europe, multi-center trial, also showing the same results, time to oral intake, 1 day versus 3 days. So we've seen those numbers again in this RCT. Solid diet resumption, 98% versus 80%, and hospital stay equivalency in terms of with SGJ in terms of adverse events. So if we follow the dominance principle, this is called the corridor set pairwise comparison. Treatment A, surgical GJ, is better than B, SEMS. That's the Susten trial. Treatment C is better than B. That's the EUSGE, better than SEMS. The DRAGU trial from Hong Kong, from Asia. Treatment C is equivalent or better than A. This is what we saw now at the DDW, the so-called GOOSE and the Enduro trials. So then the conclusion should be EUSGE should be first-line treatment. It is dominated, the treatment B, that is the duodenal stenting, is dominated and should not be performed. So that's if we follow this pairwise comparison reasoning. But I do want to highlight that we need to be selective in who undergoes this treatment. We should observe the caveats or the warnings from the ESGE that we should not do this in patients with significant ascites, malignant wall infiltration, and peritoneal carcinomatosis. And we should be reminded of this study showing that there can be significant complications. You need to do this in an expert setting. That means an expert operator, but also expert resources and an expert multidisciplinary team. Because We have all these wonderful tools now, and they embolden us to push the envelope, but we must always remember and stay very humble that the high surgical risk patient who can benefit the most from what we can offer them with endoscopy, these are the very same patients who fare worst with surgery, primum non nocere. Thank you.
That was truly fantastic. So, speaking in favor of the duodenal stent for gastric outlet obstruction is Sham Tucker. He's coming from West Virginia University, where he is professor and director of advanced therapeutic endoscopy.
Thank you, Kusum, and thank you to the entire course directors. It's been an honor and pleasure to be a part of this amazing course. It's been seen so much and learned so much, and looking forward to having some fun in this debate here with you, Ken. I'm going to take a little different approach here, obviously, and talk about duodenal stenting as simpler and lower risk. So, you know, when I kind of thought about this, I kind of thought that this was more like David versus Goliath, right? And I think the resemblance is there. I mean, I've got short hair. Ken's got this long, luscious, flowing hair, and he's more of the Goliath in our field, right? So you know, when we had our WISE course this past spring, my surgical colleague, Dr. Brian Boone, did a debating surgical GJ versus US GJ. And he did a really good job. And so I asked him, what are your strategies to win? And so he said, you got to attack your opponent. Go after his credentials, go after his character, go after his motivation. And so you know, unfortunately, when I try and go after that on Ken, he's got 200 publications, several books he's written. He's got a Master Endoscopist of the Year award, and kind of the list just keeps going on and on. If you look on his foundation website, you know, his career-long passion is endoscopy, innovation, and teaching. So I don't think there's a lot there to attack. And then motivation, I thought, well, there's this little interview that comes up, so maybe he's in it for some secondary gain. And if we can play the video, can you play the audio for me? You're not going to hear it here.
And you can just cure that patient instantaneously.
Well, you can see there he's pretty in there for the right reason. So I guess we're just going to have to rely on the data. And let's clarify the statement. Duodenal stenting is simpler and lower risk. So let's talk. As a background, as most of you know, gastric outlet obstruction is a result of mechanical blockage of gastric emptying. Most common cause is malignancy, and you can see all these causes why. And so what are the advantages really of duodenal stenting? Well, it's widely available, doesn't require EUS expertise or specialized lumen-opposing metal stents. It's a faster procedure. Shorter procedures can be performed under moderate sedation. It has high technical success, slightly higher technical success than GJs in real-world settings, and several studies have shown us that. It's ideal for short-term palliation, excellent option for patients with limited life expectancy. Lower upfront costs, less expensive in terms of devices, equipment, easier logistics in institutions, and lower immediate bleeding risks. Additionally, it can be done as an outpatient. It has no need for lumen-opposing metal stents that aren't universally stocked, and it's better for patients with ascites or peritoneal carcinomatosis. And then there's patient factors, very ill, might be poorly tolerant to long procedures or anesthesia and complications. And so certainly I think duodenal stents offers tremendous amount of advantages. But just let's diving into the data, as Ken alluded to, you know, the first duodenal stent description was made by Dick Kozera back in 1992. We have more than 30 years of experience with duodenal stenting. EUSGJ has only been around since really the mid-2010s, and the technique has not been perfected. And we have these 4 different ways of performing EUSGJ, and they include, you know, the freehand approach, wireless the West technique, the EPAS technique, and the retrograde US enterogastrostomy. And, you know, when you see 4 different techniques of doing something, it tells you that there's a reason why. There's no good way of doing it, okay? And so for that reason, I think, you know, when it comes to duodenal stent, I think there's only one way to really do that. But let's get more into the data as well. So, you know, the DuoFlex study, this was the first prospective study that looked at enteral stenting, 51 consecutive patients, very high technical success, very high clinical success, median stent patency of 307 days. When you look at the prospective data beyond that, again, very high technical success rates, very high clinical success rates. Yes, there's some evidence of stent dysfunction, but in the majority of these studies, they were all managed with stent placement, and there was no differences in survival. Over 75% of the cases were managed with stent placement. When you look at meta-analysis, here's a meta-analysis of EUS-GJ versus duodenal stenting versus surgical GJ. 61 articles included. Technical success was higher for duodenal stenting, lower rate of bleeding with duodenal stenting, no difference in clinical success, and yes, higher rate of reintervention. Again, this can be managed endoscopically for the most part. And then here, another meta-analysis across 5 studies, only difference was evidence of need for reintervention. So, going into that, does the stent dysfunction affect survival? Well, this was a study that was published in BMC Gastro, and what they found was the reintervention rate was 12%, and all were managed endoscopically, no difference in survival. And the only thing that actually affected survival was if you had to intervene on biliary stents. They found that those patients were likely going to have a poorer survival. And the Dragoo study, I'm glad Ken brought this up, prospective study of 97 patients. And, on the face of it, it looks like, okay, this is a study that potentially shows that, EUS-GJ is superior. They found initially that stent patency was better in the EUS-GJ group, and the reintervention rate was higher in the enteral stenting group. And so, should we crown a Goliath king here? But I don't think so, because this paper was actually retracted, and David struck back here because a reader found that there were errors in the way the analysis was performed. And so the Kaplan-Meier analysis was reperformed, and there was actually no difference in stent patency. That means from time to stent placement to time for an intervention due to stent dysfunction, there was no difference between enteral stenting and the EUS-GJ group. And so as such, there was no difference in the duration of stent patency. Additionally, if you look at the way this procedure was performed, it was using the EPAS technique. Now, the EPAS technique, we saw a great example of it from AIG yesterday, but this is not commercially available in the United States, okay? It is also, if you look at the methodology in the paper, they describe EUS gastroenterology procedures were performed by expert endoscopists who had performed more than 10 EUS-GJ procedures with the EPAS device previously. Before the start of the study, a physical meeting was held to explain the use of the device. The participant institutions were then provided the device to gain the required experience to participate in the study. When difficulties were encountered, the principal investigator was contacted to provide online proctorship during a real case. Okay, and the principal investigator was the guy who invented the EPAS balloon, Takao Itoi. All right, we would all love to have him over our shoulder with his device in performing EUS-GJ, but we can't. And as such, I think you got to take this study with a grain of salt. While it did show some clear benefit of EUS-GJ, it's a procedure for tomorrow. We're not there yet in our country today. And so, just clicking forward. So let's look at the duodenal stent procedure now. So here you can see a gastric outlet obstruction, and as compared to the way EUS-GJ is performed, here it's simply placing a wire across. Many are familiar. You advance your stent over the wire, and then with some fluoroscopy, you can deploy the stent. And this looks a lot simpler to me than to you. I don't know what the panel thinks, but I'm pretty certain this is pretty simple. So, now that we've showed that, let's talk about the potential complications with the EUS-GJ. Multi-center retrospective series of 467 patients, up to a 10% misdeployment rate that occurs. Now, in this, most of these cases occurred in the first 13 procedures that endoscopists performed, but you have to be prepared to salvage. So if you're going to take this on, you have to be willing to understand that you may have to perform a notes reintervention. Here you can see a misdeployment of the distal flange of the EUS-GJ that can then be recaptured over the wire, and then a new stent sent in and then redeployed. And so when we talk about these misdeployed stents, what were the outcomes? 6 severe cases, 1 fatality, and 5 patients required surgery ultimately for the salvage of the misdeployed GJ stent. This is a case, and so, I think there's a learning curve that obviously goes with this. And, this was recently published in Gastrointestinal Endoscopy that shows it really takes 25 cases to gain proficiency for EUSGJ and 40 cases to gain mastery. When it comes to enteral stenting, of course, no firm guidelines on how to achieve mastery, but in terms of volumes, but in essence, it's an understanding of the procedural equipment, devices, technique, and then ultimately through that in the training. And so one of the other points to bring up, Ken talked a little bit about mal-deployments in the MAUD report. And, this was a case that I did an EUSGJ on. And unfortunately, I had this stent into the jejunum and the stent did not deploy. When I went to deploy the second stage, you can see here that the delivery system is glued together at the handle. And so when you went to step 2, it's separated. And I think Ken can probably recognize that as well. But nonetheless, there's obviously mal-deployments that can happen with any type of stent, any type of device, okay? I think the key here is that, yes, there was this MAUD report that came in on enteral stents, but that MAUD report, talks about enteral stents that are, again, in the luminal tract. And while there's a 12% perforation rate in those MAUD reports, here you can see whenever we have a device malfunction with the lumen-opposing metal stent, you have a hole in the jejunum and you have a hole in the stomach that you have to prepare for. So in this case, obviously, fortunately, we were able to salvage and the patient did well, but certainly mal-deployments can also happen with these devices as well as they become more perfected. So what about candidates or contraindications for EUSGJ? I think you've got to obviously consider it cautiously in patients with ascites, Leonidas plastica, or peritoneal carcinomatosis. You know what? In all these cases, however, duodenal stents can still work as well. Whenever we talk about placing USGJs, if you decide it's appropriate to move forward or you want to do it, I think it's really important to have multidisciplinary discussions around this. And the reason why is that we just don't have enough data to adopt that as a standard of care. And so resectable tumors as well. Our surgeons believe in neoadjuvant therapy. We believe in neoadjuvant therapy, but our medical oncologists have been pushing back to us. Why do you guys want to give neoadjuvant therapies to the surgeons to basically say, just take out the tumor? The randomized controlled trials have not really demonstrated or have been controversial over the benefit of neoadjuvant therapy. And so if we're going to place a EUSGJ stent, the question is where are we really placing this? My surgeon will ask me when I place it, because he's going to have to take down that fistula, where am I putting it? And the best answer I can give him is proximal somewhere. We'd like to believe it's going to be in the proximal jejunum, but the reality is I'm just identifying a loop somewhere in the small bowel that's hopefully going to palliate the symptoms. And so, that's a fistula then that the surgeon has to take down, and they have to obviously be comfortable with it as well. And then finally, for unresectable tumors, more and more we're seeing that the coating on these lumen-opposing metal stents can get ingrowth and they can get overgrowth. So expert opinion right now is that these need to be changed out every 6 to 12 months if you're going to use those. And then finally, there's been changes in outpatient care. In 2026, just a show of hands, how many of you have access to an endoscopy center or have worked in an endoscopy center or plan to work in an endoscopy center? Anyone out there that does? So, I guess it's late on Saturday, so not many, but, come 2026, there's going to be a lot of opportunity for interventional endoscopy in the ambulatory surgery setting. EUS, ERCP, endobariatrics, thanks to this big, beautiful bill, will have the opportunity to perform these procedures in the endo center. And so what does that mean for patients and providers? I think, certainly thinking about doing EUSGJs versus enteral stenting, I think duodenal stents will offer an advantage here with respect to procedural risk, equipment cost, device costs, and medical legal risk. So, this is just another opportunity where I think you got to be really considerate as to whether duodenal stenting or EUSGJ is the right approach. And so just some final things to touch on. Ken talked about the Goose trial. We were one of the centers that were a part of it. And so I had a feeling it was going to come up because obviously I'm talking on the other side here. But the primary endpoint in this was, of course, a composite endpoint of being able to tolerate diet. And yes, we found advantages here of EUSGJ over surgical GJ. And this work that was presented at DDW, it's been accepted to gut. But it's important to realize that this was, again, comparing EUSGJ to surgical GJ, did not compare it to enteral stents. And actually, if you look through when this becomes published, the methodology is going to be critically important because 42 patients were excluded. from this study that were evaluated to start with. And they were excluded primarily because the surgeons felt that they were not good candidates for potential surgical GJ. So a lot of these patients ended up getting enteral stenting. I think that's an important point here is that, if they're not going to be a candidate, taking this information and understanding that while EUS GJ is superior to surgical GJ, I think it's a bigger leap to say that it's definitively superior to enteral stenting. And so the randomized controlled trials, Ken talked about the stent trial. There were two other randomized controlled trials that looked at enteral stenting versus surgical GJ, and both of those found in favor of enteral stenting. The stent study, while it didn't find necessarily in favor of enteral stenting, if you took out the reinterventions, you actually found that there was some advantages in enteral stenting, but overall the long-term benefit was towards the surgical GJ. So, I think taking that in with a grain of salt, I think there's still a little bit more controversial in that regard. So, and then finally, society guidelines, ASG guidelines don't recommend, don't even mention EUS GJ, rather talk about using enteral stenting for those with short-term and surgical GJ for those with long-term potential palliation. And then the AGA and the ASGE guidelines really say as an alternate towards surgical GJ for EUS GJ. So I think, again, we need more data to help us here. But, kind of going forward, I think one of the big things here is that, what should we be focusing on? But instead of moving away entirely from enteral stenting, what we should be focusing on is how can we improve enteral stenting? And, here are some predictors of duodenal stent dysfunction. This was a study published in Surgical Endoscopy that found these factors were associated with stent dysfunction. Karnofsky Performance Scale, ascites, lack of stent expansion resulted in the likelihood of stent dysfunction. So perhaps in someone that has good performance status, those would be individuals to perhaps consider EUS GJ on. Someone who undergoes cross-sectional imaging, we're not seeing the stent open up appropriately. This might be someone to reconsider an EUS GJ on as a salvage treatment if the duodenal stent didn't work out well. Additionally, there are other studies that have looked at patient-specific factors to predict technical success in EUS GJ, and I think this is where we have to take it, is looking at really what works best for what patient in what scenario. And so to conclude, I think duodenal stents offer a simple technique and provide safe method for palliation. They have a high technical success, clinical success, and stent patency. There is a higher reintervention rate, but again, the majority of these can be managed with stent within stent. You can overcome the contraindications for EUS GJ, and it's acceptable for most resectable tumors versus upfront surgery, and may provide better value in an outpatient setting. And ultimately, though, I think we've got to individualize the treatment for the patient. And I hope I've showed you how David prevailed over Goliath. Thank you all for your time, and I hope to see you at the WISE course next year.
That was great. Our last talk of our session and of RMIE will be provided by Sachin Wani. He's been my mentor for many years, and I've been honored to call him my colleague for the past year. He wears many hats at our organization, but and a few of them are listed on the slide.
Thank you so much, Kusuma. What a fantastic 3 days we've had, right? It's my task to talk to you a little bit about how we can maximize impact and minimize overuse and endoscopic surveillance for Barrett's esophagus. And this is what I hope to cover in these last few minutes. Talk to you a little bit about why we perform surveillance for our patients with Barrett's esophagus, what are the goals, and then answer this fundamental question. In 2025, is surveillance still worth the effort? What are some of the challenges that we face when we perform surveillance for these patients? What can we do as a community of endoscopists to improve outcomes, interventions that you can use every single day in your endoscopy practice? And I'll do all of this in the setting of most recently published guidelines, shed some light on some of the ongoing studies that we're doing here at the University of Colorado and across several other sites. So these are the guidelines that I will be focusing on. These are the guidelines that we published through the American College of Gastroenterology, and these are the most recent guidelines that will be coming out out through the AGA, which will be published in the November issue of Gastroenterology. The amazing thing about doing this line of work is that you get to work with such amazing individuals, some of the smartest individuals in the field. So let's answer this basic question. What's the goal of doing surveillance for patients with Barrett's esophagus? I think everyone in this room recognizes that esophageal adenocarcinoma is an important health problem. This is still a cancer that continues to have a dismal 5-year survival rate of less than 20%. Our goal of doing surveillance is fairly simple: to identify those patients with Barrett's with high-grade dysplasia and early cancer, so that these patients can then undergo endoscopic eradication therapy and avoid the morbidity and mortality related to esophagectomy. Our ultimate goal, of course, is to improve outcomes related to esophageal adenocarcinoma. So let's talk a little bit about what I was tasked to do: misuse of endoscopy. I will tell you that there is a growing body of evidence similar to this concept of missing lesions during colonoscopy, that we can miss lesions that harbor high-grade dysplasia or cancer within the Barrett segment, and hence the analogy with post-colonoscopy colorectal cancer. In order to improve the quality of endoscopy that we perform for our patients with Barrett's esophagus, we coined these two terms. If there's one thing you can take away from this presentation, is to understand the terminology of post-endoscopy esophageal cancer and post-endoscopy esophageal neoplasia. And now there's a growing body of literature describing how we can potentially miss high-grade dysplasia or cancer when we perform screening or surveillance endoscopy for our patients with Barrett's esophagus. Now, this is a really important study where we looked at a population of newly diagnosed Barrett's esophagus. We've been fortunate enough to collaborate with our colleagues in Sweden, Jesper Lagergren. I don't know how many of you remember his landmark paper. He's the guy who first showed the association between gastroesophageal reflux disease and esophageal cancer. And I've had the honor and privilege of working with him now for over 4 to 5 years. So what we did with this group is identified patients with newly diagnosed Barrett's esophagus, followed these patients for about 4 to 5 years, and identified how many patients were diagnosed with post-endoscopy esophageal cancer after an ostensibly negative exam for high-grade dysplasia or cancer. It wasn't surprising to us, because these estimates were similar to what we showed in a systematic review and meta-analysis. 25% of all cancers were categorized as post-endoscopy esophageal cancer. So this clearly undermines what we're trying to achieve when we perform screening or surveillance exams. What was also disturbing from the study was that when we did a time trend analysis, we found that there has been really no change in the proportion of peak cases over time. And this sort of aligns with the time where we've had all these advancements in the high-tech scopes that have narrowband imaging, scopes that have high-definition white light endoscopy. So really disturbing statistics when you look at this population-based cohort study. When you think about why we see post-endoscopy esophageal cancer in our practice, the vast majority can be attributed to missed lesions, us not spending enough time inspecting the Barrett segment, the lack of knowledge of the patterns that are associated with dysplasia or early cancer, us not taking biopsies using the Seattle biopsy protocol, and some of this may also be attributed to the inter-observer variability that we see among our pathologists. There is another category. I don't know how often it contributes to peak and peen, but that's a question that is being addressed at the present time, which may be rapidly progressive cancers due to accelerated pathways of neoplasia. I also want you to be aware of this trial, which will be published again in the same issue as our guidelines, which is in the November issue of Gastroenterology. This is the BOSS trial. This was presented at the plenary session at DDW this year, which basically compared surveillance versus endoscopy at need for patients with Barrett's esophagus. This was largely conducted in the United Kingdom, where patients underwent surveillance every 2 years, or they underwent an endoscopy if they had symptoms. I will tell you that the study really does not describe what were the motivating factors for doing these at-need endoscopies. They had over 3,400 patients followed up for a minimum of 10 years, and they showed us that there is no difference in overall survival or cancer survival. Now, before you jump to conclusions and state, wow, based on this RCT, I should probably stop doing surveillance for patients with Barrett's esophagus, let me just highlight some of the key limitations of this randomized controlled trial. For one, it did not report on esophageal cancer-specific mortality. They basically included cancer-specific mortality in their endpoint of all-cause mortality. They were underpowered for the outcome of overall mortality. There was significant cross-contamination between the two groups. Basically, there was no difference in how often patients were being brought back between these two arms in the randomized controlled trial. They also included patients that we would never enroll in surveillance programs in the United States. They had patients who did not have the true definition of Barrett's esophagus that requires the diagnosis of intestinal metaplasia, and there were several generalizability issues as well. So we tackled this problem head on in our guideline document, and we looked at observational data that have shown us that when you perform surveillance endoscopy for patients with Barrett's, you're more likely to diagnose patients with Barrett's with high-grade dysplasia, early cancer. We do see a reduction in cancer-related mortality when you do enroll patients in surveillance programs. So based on the available evidence, granted, some of this is low quality, the AGA still is going to recommend that we continue performing surveillance for our patients with Barrett's esophagus. This is a conditional recommendation with overall low quality of evidence. Now, what are some of the practical interventions that you can use in your endoscopy lab to improve outcomes related to surveillance endoscopy? Now, we did two cases. One was done by Jen Fan, and I did an exam, again, demonstrating the basic tenets of a high-quality exam for patients with Barrett's esophagus. We obviously want to use the best endoscope we have in our endoscopy lab. We will use a combination of high-definition white light endoscopy and narrowband imaging after we've cleaned the distal esophagus of all debris, after we've identified the landmarks at the lower part of the esophagus, and we do a careful pull-through. You saw the images on high-definition white light endoscopy, and there is clearly a visible lesion in the proximal portion of the Barrett's esophagus. You should be using standardized classification systems such as the Prague classification system describing the circumferential and the maximal extent of the Barrett segment, and use the Paris classification for any visible lesion. I'll tell you that the use of narrowband imaging or virtual chromoendoscopy not only helps you predict what the histology is, but it also guides your resection. So in this patient, if you just look, I'm guessing you guys are not seeing my arrow, but if you just look at the top of that visible lesion on high-definition white light endoscopy, you would be tempted to only perform resection probably from the 4 o'clock position to the 8 o'clock or 9 o'clock, but you can actually appreciate that the vascular pattern and the mucosal pattern changes starting from the 2 o'clock position, and it goes all the way to the 10 o'clock position. So this is how you can actually use virtual chromoendoscopy to guide your resection. And only when you've accomplished all of these above steps should you be taking biopsies, which should be taken using the Seattle biopsy protocol, which is obtaining biopsies every 1 to 2 centimeters in a 4-quadrant fashion. And you should be taking targeted biopsies from any visible lesion, no matter how subtle that lesion may be. Another important contribution from our guideline document that will be coming out is that we've actually created a library of all visible lesions, some that we've seen in our clinical practice. So our hope is not only to highlight these basic principles of a high-quality exam, but also these images that you can refer to that highlight all the different sort of visible lesions that you can encounter when you perform surveillance for patients with Barrett's esophagus. Here's a cartoon of the Paris classification system. Dr. Gabor went over this, so I'm going to skip this. This is what our guidelines state. You should be using a combination of high-definition white light endoscopy and virtual chromoendoscopy, given the fact that we now have 12 randomized controlled trials that have conclusively shown us that when you use this combination, you will improve detection of Barrett's-related dysplasia and early cancer. And you should combine this with taking biopsies using a structured biopsy protocol. Do not only take biopsies based on the findings on virtual chromoendoscopy. You have to combine these two sets of biopsies. The next important question to ask ourselves is, can we use clinical and endoscopic characteristics to guide risk stratification for patients with Barrett's esophagus undergoing surveillance? And you can see that there are a whole bunch of different risk factors that you can use to guide your surveillance exams. There have been prediction models that have been developed, but none that have actually been adapted in routine clinical practice. What's one risk factor that you can use in your clinical practice is the length of the Barrett segment. Our guidelines state that if you have a Barrett segment that's 3 centimeters or longer, these patients should be brought back every 3 years. For patients with Barrett's length less than 3 centimeters, these patients could be brought back every 5 years. And this is where, again, misuse of endoscopy can happen. You heard Dr. Pohl talk about this. When you bring patients back for endoscopies that are not indicated, we see this happen way too often. When I see patients in my clinic, they tell me that they've been undergoing endoscopies every year. Then my brain starts ticking. Maybe these patients have had dysplasia in the past, and that's why the endoscopist is bringing them back on an annual basis. But then when I look back at all the endoscopies that they've had, they were all diagnosed with non-dysplastic Barrett's. These are all unnecessary endoscopies that were done. And when we looked at the GI Quick database, Doug Rex talked about this benchmarking registry. Nearly 30% of all patients diagnosed with non-dysplastic Barrett's esophagus are brought back too soon. We've got to start adhering to the guidelines that have been published by our GI societies. Another important point to remember, the diagnosis of Barrett's is made when you have columnar-lined esophagus that's at least 1 centimeter. When you take biopsies and you find intestinal metaplasia, only then should you make that diagnosis of Barrett's esophagus. We see this way too often where patients with a normal squamocolumnar junction gets a biopsy. That biopsy shows intestinal metaplasia, which, by the way, is intestinal metaplasia of the gastric cardia. This patient then wrongly gets diagnosed with Barrett's esophagus and continues to come back for surveillance exams. So again, this is a practice that has to stop, and we all need to remember what the definition of Barrett's esophagus is. The next important question is, can we do something better than dysplasia? That's the best biomarker that we have to risk stratify patients with Barrett's esophagus, right? We know that Barrett's can progress in a stepwise and a probabilistic fashion, going through these stages of non-dysplastic Barrett's to low grade, to high grade, and then to adenocarcinoma. can we do better than the degree of dysplasia? And I will tell you that there is a tremendous amount of work that's being done at the present time to use biomarkers alone or in combination with clinical risk stratification tools. Again, similar to the point that I made this morning when the panel was talking about biomarkers for pancreatic cysts, I think it's really important to understand how well these biomarkers work in clinical practice. What are the diagnostic characteristics? We need to understand what the false positive rates are. P53 staining is one that has been used for the longest period of time. We have this tissue system pathology test or TissueCypher that uses a panel of biomarkers. I'll tell you where the guidelines stand on the use of these biomarkers. We chose not to provide any recommendation for the use of P53 or TissueCypher in addition to standard histopathology for patients undergoing endoscopic surveillance. A lot of work is being done for additional biomarkers from brushings. This is work that we are doing through a grant that's funded by the NCI in collaboration with the Case Western team looking at aneuploidy to predict progression in patients with Barrett's esophagus. What can we do to improve our detection of dysplasia when we do take surveillance biopsies? You could use a brush. Wide area transepithelial sampling has been shown to improve the dysplasia detection, but based on the available evidence, again, the AGA chose not to make a recommendation for routine use of WATS for patients undergoing surveillance for the diagnosis of Barrett's esophagus. I told you I'll shed some light on some of the ongoing studies. SWOT-PE study is a multi-center randomized control trial that will really answer this fundamental question. Can we brush instead of taking biopsies using the Seattle biopsy protocol? So the study involves patients with Barrett's where they get randomized to either forceps biopsies or WATS sampling, and every patient undergoes both sampling techniques, and our goal is to compare these two sampling techniques for the diagnostic yield of neoplasia. This study is also powered to look at the adjunctive role of WATS to the Seattle biopsy protocol. And this will, of course, lay the foundation for future risk stratification models. I pretty much can talk an entire session on the controversies related to low-grade dysplasia. In the interest of time, I'll just tell you what our guidelines state. Our guidelines state that you should use a patient-centered strategy. Recognize that both endoscopic surveillance and endoscopic eradication therapy are acceptable treatment strategies for patients with confirmed low-grade dysplasia. There's several knowledge gaps in the management of patients with low-grade dysplasia, and we are in the midst of the only randomized controlled trial for low-grade dysplasia here in the United States, where patients with confirmed low-grade dysplasia are being randomized to treatment or surveillance. And of course, we're looking at the outcome of neoplastic progression. But in addition to this, we will actually be looking at all contemporary biomarkers to see if these biomarkers can predict progression. We're looking at patient-centered outcomes. And for the first time, we've created a live biorepository where samples from 31 centers in the country are being sent over to the University of Colorado. Incredibly grateful to my co-PIs and to the NIDDK for funding the study. And this is a slide just demonstrating all the participating centers. And I'm just really, again, grateful to the NIH for understanding how important esophageal cancer is and actually funding the first trial related to Barrett's and to esophageal adenocarcinoma. We have this flow chart that will be included in our guideline document. Again, the key takeaways from this presentation are ensure that you're really defining Barrett's using the correct definition. You must have column-lined esophagus, at least of 1 centimeter with intestinal metaplasia on histology. Patients should be brought back every 3 to 5 years based on their baseline histology. And as long as you've documented their length, these patients should be brought back either at 3 to 5 years. ensure that you perform your endoscopic examination using high definition white light endoscopy and virtual chromoendoscopy. And for patients with indefinite for dysplasia, ensure that they are on high dose PPI therapy and bring them back in a year. For low grade dysplasia, you should be using a patient centered strategy. Thank you so much for your attention.
We'll now open up the microphones and poll everywhere for any questions.
Thanks for great talks, great learning. This question is for more relevant to the poem question. Any thoughts on whether TIF will become an option for patients with GERD following poem?
Yeah, I think it's actually a very, very good option for that because, those patients typically don't have a hiatal hernia, and and we can manage those patients endoscopically ourselves. And I think where Jen works with the Ken Chang, I think they've done some preliminary work on that. So certainly a very good indication. All right, what do you guys think about the debate? Who thinks that duodenal stent is the way to go?
It wasn't a debate because if we look at the titles, right, mine was that
That's all I wanted.
E is effective. And basically, I think we can all agree it is effective. It wasn't whether it's the first choice, right? And I think that's where the debate really would come if I were arguing that this should be first line therapy. And I agree. Wish I am that we're not there yet. It's not ready to be first line therapy, but it is true that in expert centers where there is, not just the expertise, but the experience and the resources at a multidisciplinary level, I do think that it's reasonable to implement it as first line, but that would be very restricted to these tertiary, referral centers.
Ryan, yeah.
And then your title was that it's what's simple and low risk. The only modification I would have made is low significant adverse event risk.
Well, I would say, lower risk as compared to USGJ, the way we can perform it in this country right now. But again, once you have the experience, as Ken's alluding to, and as shown in that study with respect to proficiency and mastery, then it becomes more able to do. But you're making a perforation in whatever organ you're going into, and you have to be prepared to salvage that. And as long as you're prepared to salvage that and prepared to go in with that mindset, then it becomes something potentially worth engaging in.
Yeah, I can't agree, more that you have to be prepared to manage a complication. And this is without question the most technically challenging and hazardous of all the LAMS procedures that we performed.
Yes.
And it is the very last of all the LAMS procedures that you should start doing after you have mastery of the others.
Yes, yeah. Agreed. And just one thing, like the MOD reports, right? So 12% rate of perforation with the duodenal stents, right? When the stent's misdeployed. But when the stent misdeploys with the USGJ, it's 100% perforation, right? So that's something to understand. You've already made a hole and you have a stent dysfunction. So in those cases, devices are going to always have their pros and cons, and you just have to be prepared for that.
Yeah, I did highlight that there were 3 patients that in that randomized control trial that went on to surgery after failed EUSGE. And there were also fatalities reported secondary to maldeployment. My issue is because I've been to Korea many times, or Asia, where I get to see these amazing duodenal stents that are not available in the US. One of the problems, we're using mainly the wall stent. This isn't to pick up that one necessarily. I know there's others. There are a few Korean stents available now, but they really are not. They don't have all of the the modifications that I've seen that are available in Asia, namely that they are really more compliant. They conform to the duodenal C anatomy. My issue is really what Dick Kozarek pointed out in his original report there, which is that these stents, they straighten. You know, they want to straighten out. They look great on the brochures, right? They make a nice C curve and all, but as soon as you deploy them, they want to straighten out. And that's really, I think, the problem when using these in the duodenum versus, you know, the esophagus, which is obviously a straight pathway.
Ryan.
So regarding GJ, two questions, but related. Do you guys always perform, like, make a duodenal stent fail before you'll go to a gastroenterostomy, number one? And then number two, do you wait for a patient to become completely obstructed, or do you kind of bite the bullet early, realizing this is the direction we're headed? Let's just kind of pull the trigger now. What are your thoughts on kind of early gastroenterostomy?
So I think that's a great question. You know, at our center, we have a preference for EUSGJ. And the reason why is we have a place, you know, I work at a place where, you know, there's a very poor socioeconomic status to begin with. It's very hard for patients to come back. They come from very far away. And, you know, sometimes some of these patients can't afford transportation or arrange transportation, let alone, you know, bus tickets at times. So, you know, it's a very difficult situation at times. And I know that if I know that they're not going to get therapy, then yes, we'll potentially go forward with the EUSGJ. But I think our center is a little bit different in that regard because we've done a lot of lumen-opposing metal stent placements now, and we've participated in several studies in that regard. So in terms of our experience with it, we feel good about it. And then at the same time, it's only if things line up appropriately. I think in more urban places where you might have you know, more reliable patients, it might make sense to go with the duodenal stent first.
It's actually been many years since I placed my last duodenal stent for an inoperable malignant obstruction. But I still place duodenal stents fully covered for benign conditions because we, you know, are still waiting for further data on the use of EUSGE for benign conditions. There are two exceptions, maybe afferent loop syndrome would be one, and the other would be SMA syndrome. But apart from those two, you have to be, you know, very cautious because that would, we just don't have the data to justify doing that. So if I do place a fully covered, I'm always concerned about the possibility of blocking bile and pancreatic juice drainage. So it's very important to monitor that. And I always suture them in. And I'm very aggressive with the suturing because they do migrate very easily.
What is your preferred stent when you use a fully covered duodenal stent? Because we've had patients refer to us who have been sutured and have had fully covered stents placed.
They
that have
migrate.
migrated.
I know.
Yeah.
I know.
So what's your preference?
In
'Cause I
terms of
feel like
method?
that of the type of stent, because I feel like the through the scope stents, even though they're such easy to place, have less radial force, so they're actually higher risk of migration even with suturing.
Yeah. Well, so I can share with you, and we're doing a prospective study now. So Mycotech has a segmented stent. What I like about that is it actually does conform because it's segmented. It conforms better to the duodenal C configuration. You know, I'll do a purse string suture literally around the proximal end to the pylorus. So I use the pylorus to really anchor that proximal end of the stent. So I tried for a while trying to suture at the bulb because if you look, when you do endoscopy and you go into the bulb, you take a sharp right turn to the second at the apex, right? So I thought, well, maybe if I don't extend the proximal end to the antrum, that might reduce the risk of migration. So for a while, I was trying to place the proximal end in the bulb. The problem is the bulb is very, very thin. It easily ulcerates. Overgrowth occurs quickly. So there's no easy solution. We need a better duodenal stent. And I think that really is sort of one takeaway here is industry needs to, I mean, they're already partly available in other parts of the world. We need better duodenal stents.
This has been a really great discussion. I do want to get to some of the poll everywhere questions. And then we'll actually, Dr. Edmundowitz, would you like to ask your question?
Go ahead.
Okay, so the first poll everywhere question is for Dr. Bilal. Do you use gastric emptying study or other objective studies post GPOEM to check for efficacy or success?
Yeah, that's a great question. I brought it up yesterday to the panel.
Can I suggest really brief responses because we have to wrap up?
Yes, so we talked about this yesterday when we had the panel discussion as well, when we were doing the actual case to Ryan. We do gastric emptying study in 2 to 3 months after to just sort of have a baseline efficacy, but not have always found it to correlate with symptoms. But I find it helpful to have a conversation with the patient that, your gastric emptying study was 39% emptying at 4 hours, and now it's normal. So at least that we know that the pylorus part is working fine and things like that. But I wish that we had better data to correlate on symptoms. But in our practice, we do that.
The next question is for Dr. Fan. Which future technology are you most excited about for endoscopic therapies for obesity?
The limiting factor to wide adoption is how complex the suturing platform is, and there are easier suturing platforms that are under investigation. So we'll see how those come out and how they stack up.
The next couple questions have to do with EVT. I think what I've been most impressed about with EVT is that, we're often using them when patients have had failed esophageal stents or overlapping stents. And EVT has been really remarkable for a number of patients who are not candidates for surgery. And we've been able to heal their defects. If you are looking to start implementing EVT at your center, you need the buy-in of your surgeons. Our surgeons are really the biggest kind of referrals for EVT. They've seen that it works, and they are often asking us to perform EVT for their patients. So I think that's the first step, and then really educating your nurses, your floor nurses is also imperative.
I don't know if it's available in the US, but I've read about a vacuum stent, a stent with the sponge mounted on the proximal end or something like that.
Not yet.
Can you comment on that?
Yes, I actually am not sure if it's available in the US either. We haven't used it, or we haven't, sorry,
That
it's
sounds
not available. Yeah, I think the question is really going to come down to cost, and if it's more what the difference in cost is, making your own sponges versus using
But
a
the
stem
cost,
like this.
you're going to save the patient the hospitalization because they have to stay in the hospital, for the suction.
Right.
And they can go home.
Yeah. Although I will say that there was one center in Texas that has been sending their patients home with sponges. It's not something that we're doing here, but
Dr. Edmundowitz? Yeah.
Yeah, I want to close with one last comment, Jen, or maybe you'll make the comment. So we've seen this marked transformation in the obesity situation with the oral meds. Do you think endobariatrics is going to thrive, or do you think endobariatrics is going to become a kind of therapy for failures of oral medication?
To be honest, I think it's the latter. I think many patients will try first these what soon will be oral medications or injectable medications. And then when those don't work, they need a secondary option. And we know that surgery is only becoming more invasive with like SADs and all these things, that endoscopic options are available. I think there's millions of people that need help. So we're going to thrive. And whether we thrive primarily or secondarily does not make a difference to us, I think.
Yeah.
we have a couple more questions on a poll everywhere. Raj, do we have time?
I think we need to stop.
Okay.
The fact that we have to reluctantly close a session at the end of the day, people aren't inching to get out except to catch flights, is really remarkable. Do you have some comments?
Oh, no.
Oh.
Go ahead.
So we just want to close this out and tell you that we're really appreciative of all the faculty taking time away from their practices, their families, lending their expertise to really make this, if not one of the best Rocky Mountain interventional endoscopy course that we've had here. And a big thank you, not only to our industry partners, but to Christy Click. Christy, we keep thanking you, but boy, this is just, we put on quite an event. And these are all of our industry partners, platinum, gold, silver, and that's about it. What do you got?
No, that's it. Just thank you so much, guys. We look forward to seeing you at the next RMIE.
Oh yeah, the main thing, actually, I forgot about this. We have a reception with some food and drinks on the 7th floor. Even if you only have 15 minutes, I highly recommend you go check it out. It's a beautiful rooftop area, so we'll be heading up there.
Yep.
Actually, we need special access. Do we need special access, an elevator? No, we don't. All right, we'll see you up there.
All right. Thanks, guys.